My name is Mahmoud Salman, and I'm a master's student at Western University in BME. My supervisor, Dr. Ali Khan and Dr. Emma Jordan. And my presentation today is about solving segmentation challenges in neuroscience. And I will talk on two main points here. The first thing is the neonatal hippocampal subfields, and second thing would be the amygdala subnuclei. So our agenda today, first we will go into introduction and then the challenges, and then we will separate our problem into two pillars. The first pillar would be the segmentation of neonatal hippocampal subfields, and our second pillar would be segmentation of the adult amygdala subnuclei, and discussion and conclusion after this, and finally our future work. So actually, why to segment, why to care, to segment the subfields? This is because precise biomarkers actually come from the specific subfields and not just the whole structures. And this goes for the hippocampus and the amygdala. What you can see here actually, one second, I can make my pointer. What you can see here is a patient, is a neonatal patient that has hypovoxic ischemic injury. And we can see that there is a change in its diffusion MRI image in the thalamus region. And another study found that the hypoxic ischemic injury are influenced in adults, and it really selectively damage the CA1 subfield of the hippocampus. And actually, there is no studies to the neonatals, and this is because it's really hard to segment the neonatal subfields. And another study in our lab as well is tries to see the relationship between the children with autism spectrum disorder and the higher anxiety scores. And this was actually validated as children with ASD are associated with larger right basal nucleus as well as smaller right paralaminar nucleus. And for the amygdala subnuclei, we can divide it into almost 9 regions, as we can see here. And actually, this segmentation will be used by FreeSurfer. And our work, as discussed after this, showed that the paralaminar segmentation of FreeSurfer relative to their protocol is not that accurate, which is there's a question on this will be asked later. And so let's jump into what is the challenge in the neonatal hippocampus. You can see here actually my brain, literally my 7 Tesla scan of my brain. And we can see here the hippocampus, and this is the hippocampus tissue segmentation using a tool called HippenFold, which is a tool made in our lab, as well as another scan, which is a neonatal scan. And this is its HippenFold segmentation of neonatal 3T scan. And you can see here the comparison between the neonatal scan and the adult scans. Actually, neonatal scans are much more noisy, and this is because of motion. And another thing in neonatals compared to adults, they have low tissue contrast, and this is due to the inverse myelination patterns, because the brain is not that mature when it's neonatal. And the state-of-the-art tools like HippenFold actually performs well on adults, but fail for neonatal brain due to this extreme domain shift. And if we want to see the 3D view of this neonatal segmentation, we will see it has many breaks here, and it doesn't respect the topology and different hippocampus tissues. So this is our first challenge. And let's explain actually what is HippenFold, just to go through it. So HippenFold is trained on data from diverse population, like young adults, aging population, and one epilepsy patient, as well as neonatals actually. But neonatals are acted as a separate model. And HippenFold, from its name, what it does, it to segment the hippocampus subfields, we first need to unfold the hippocampus from the 3D space to the surface space, and then segment the subfields here. So what is going here? First thing, we are using a unit tissue segmentation, and these tissues are the gray matter, the SRLM, the MTLC, and the bile, the HETA, the endymium griseum, and the cyst, and this DJ. And the dentate gyrus is actually a subfield. So we are segmenting these tissues at the beginning. And after segmenting these tissues, they act as an endpoints to do Laplace to do the Laplace transformations and go to the Laplace coordinates to be able to unfold the hippocampus from the 3D space to the surface space. And after unfolding the hippocampus in the surface space, we can at this stage do surface registration to segment the subfields. So our work will be focused on this unit tissue segmentation. So as I said before, the unit tissue segmentation, we are cropping our region of interest and then segmenting it based on different tissues of interest to ours. And if this step actually fail, then most probably we will not be able to unfold the hippocampus accurately, and the hippocampus subfield segmentation will fail as well. So like the problem here is if we have here like a whole brain scanned with 7 Tesla, and let's just jump into the amygdala at this stage because I wanna like to be a synergy between both. So like for the amygdala problem, if we have a whole brain 7 Tesla scanned, and if we crop like the amygdala region as a region of interest for the left hemisphere, we can see that it's actually invisible, like to see the subnuclei here. We can barely see the whole amygdala, but like to separate it, it's really challenging. And this is actually really hard in 3 Tesla, or this image is in 7 Tesla. And this turns into like something like the training crisis, as we don't have no ground truth labels for the in vivo MRI. So how can we train like a standard supervised deep learning model? And actually existing tool like FreeSurfer, which is a segmented HA tool, they rely on classic atlas-based segmentation. And this atlas-based segmentation, it's biased to like their template, which is built on adult. And actually, if this image registration step fails, then if it fails and the registration fails, then mostly we will not be able to segment the amygdala subnuclei. And we can see here actually the free surfer amygdala subnuclei segmentation, and we can see that there is over segmentation at here as well as over segmentation at here. And actually, as we will see later in our results, they actually even miss some subnuclei in this view. So we will be talking on two specialized framework. Our first pillar is a neonatal framework, which is challenge is extreme domain shift because of the low contrast and the inverse myelination. And our method, we will use normal 3D unit, but like our training technique will be different because we will train using a synthetic data using SenseG, which I will explain in the next slide. And our loss will be normal dice loss. And our data sample size is 169 from the DHCP dataset with 3 Tesla scans. And our second pillar here for the amygdala, we will have both the whole brain 7 Tesla as well as the dissected amygdala region, which are both are post-mortem. And our challenge here, there is no ground truth for in vivo data. That's why we rely on the ex vivo or the post-mortem data. And our sample size, first step, like to build an atlas. And we want to build an atlas to validate our manual segmentation protocol. So we have like a sample size of 10, and after this, our model training, we will use the same SenseG technique that we used in the neonatal framework. We will apply here as well. And our data, as I said again, they are post-mortem samples, and we have both like the whole 7 Tesla brain and the 9.4 two hemispheres. And what is SenseG actually? So SenseG, like it does really has like a simple methodology which says like instead of training a normal 3D units on real data, why not to train these 3D units on synthetic data? And what the synthetic data will give us an advantage here is we can generate like almost infinite synthetic data while we will always be limited to the real data. So like how is like the synthetic data generation take place from the first place? So if we have the input segmentation labels, only the input segmentation labels, and if we do some deformation, like to introduce like patient different deformed structures, and after this, for each label from those, we will do the GMM sampling. So each structure from those will have different intensity, and we will do bias correction and down sampling to introduce some augmentation to make the deep learning training more robust. And then our inputs for training will be this down sampling image as well as this deformed label, which aligns perfectly with that. So SenseG proved that if we train like a neural network with synthetic data, like this model will be able to generalize to out of distribution data and to noisy data as well, which is our problem with neonatals. So like what we did in our neonatal framework, first here we have like the whole brain segmented using the DHSP pipeline with different brain structures. And if we want to focus on like this ROI, which is our hippocampus slide here, so like the DHCP hippocampus segmentation is this red, which is actually not that accurate. So we manually segmented the hippocampus tissue labels, as we can see here. And if we have both segmentation, like all the structures in the images, as well as like the hippocampus segmented here, we can do fusion. So we can like fuse both labels with each other. So like remove just manually segment this hippocampus segmented, which is not that accurate, and add like our manually our manually labeled hippocampus. And after this, we will only use this segmentation label as senseg to the senseg generative model. And when using the senseg generative model, like from this label map, we will be able to generate like this synthetic grayscale image as well as this synthetic aligned ground truth label. And if we use a normal 3D unit, we will be able to get a prediction, and we will use dice loss and normal backpropagation to optimize our model during training. And for the testing and validation will be done only on real input images and do not synthetic images to measure its robustness. So let's test this trained model on the DHCP dataset. And we will compare actually with our baseline, and our baseline is a normal unit trained with real data. And we choose this baseline because it's the current model used in Hibbenfold. And this model is trained on real DHCP data. And we can see here, relative to the DICE scores, we will have three models, the UNet, which is the current Hibbenfold, and there is another framework called Learn to Sense, which is a variation of SenseG, but instead of training only using synthetic data, we train also using only the synthetic data, but we add the real data to estimate the noise from the real population and apply it instead of just like adding random noise. So this is just a modification of SenseG, which was promising at the beginning, but by tuning the SenseG parameter, good, we got like really close results with the UNet Hibbenfold model, and this is tested on the DHCP dataset, and this model was trained also on the DHCP dataset. And if we can see here, like we have a sample, and this sample, we have here like the SenseG prediction, and here is the UNet prediction, and we can see they are very comparable to each other. But like actually, this sample it's for neonatal, yes, but it's so nice and so pre-processed and so denoised, which actually in clinical neonatal data, it's not nice like this, and they have like severe motion artifacts. So let's test our model on clinical neonatal data, which we don't have. It's ground rules, we don't have it. So when testing like our SenseG trained model on the clinical data, and we will have here a subject, this is actually the hippocampus, okay, which we can barely see the whole hippocampus here, and it would be a really difficult problem, like to segment the tissue labels. So if we use like the normal Hibbenfold unit, you will see the segmentation is a bit chunky, and as well as has many breaks here and here and here. But when using SenseG, it got us a really nice hippocampus, and it's much better than the old UNet Hibbenfold output. And even in 3D, there are like small breakings of topology here, but like as an overall, compared to the old UNet Hibbenfold segmentation, it's actually much better. And actually, we can't even like see any tissue labels like using manual raters here. So it's pretty impressive that SenseG could be able to generalize to that extent, given like this clinical data. And let's move to our second method, which is for the amygdala. So for the amygdala, we will do the same deep learning training, but before this, we have to pre-process our data. So we have here our whole post-mortem brain, and we have it's dissected 9.4 Tesla, which has much better signal-to-noise ratio, and this is a cropped 7 Tesla from this box. And actually, this whole brain is aligned to the MRI space, and this 9.4 Tesla is aligned to the subject specific, and this subject specific is already aligned to the MRI space. So like both scans are aligned to the MRI space. And after doing this, we will first do the pre-surfer SenseG model. We will segment the whole brain structures. And after this, we will do the same enforced labeling by fusing like the other structures around the amygdala, as well as we have our manually ground truth here, which we manually segmented it. And this is for the 9.40, and this is for the 7 Tesla. And we will be able to use this data to train a deep learning model with a supervised way, as well as use this data to make an atlas and validate our manually segmentation protocol. So like in terms of results, we are comparing the baseline. So the first thing, we created the amygdala left hemisphere atlas. As you can see here, like the amygdala subnuclei you can see with your eyes, like it's separated, like its subnuclei is really separated with a good way in just like this atlas. Okay. And the second thing, we compared actually like our deep learning approach with the baseline. And the baseline here is the intervariability rate of the manual segmentations on the 9.4 Tesla scans, because all the manual segmentation was done only on the 9.4 Tesla scans. And we got an intervariability rate of like 63%. And actually, our 9.4 test prediction for Sensec was 69%, which is pretty impressive. And there is another inference instead of like making an inference to the model with a 9.4 Tesla scan. We are making an inference with the same 7 Tesla scan, and we can see here some qualitative results. And we can see actually like the amygdala subnuclei are really good delineated, especially in the 9.4 Tesla. And it's not that bad in the 7 Tesla. It's slower, but it's not that bad. And this is make common sense because like 9.4 Tesla has much higher signal to noise ratio. And actually, this turns us that as the model works good on 9.4 Tesla, then we can increase the sample size on the 9.4 with our 9.4 Tesla dataset and train the model with much more samples, which can make it more robust even. And to get a sense of how our model would react to in vivo data, so we have like here in vivo cropped amygdala left hemisphere, and this is the sense-seg prediction, and this is the free surfer prediction. So like we got our dice overlap between the sense-seg and the free surfer is like 45%. However, like the free surfer compared like to our segmentation, it misses some subnuclei. It's more nice in terms of topology, but it over segments some structures here and here. So our model is not yet ready to be tested more on in vivo data, but like our model might be ready if it's trained on much more data, which we can increase, of course, because we only trained our model using 8 samples, and we left 2 to test the model performance. So like for the comparison, it's comparable to FreeSurfer, but it's not ready yet. But still, like FreeSurfer is not the best, so both are suboptimal. So for discussion and conclusion, we built 2 powerful specialized framework for unique segmentation challenges. Our first one achieved actually robust generalization to low contrast and out of distribution neonatal clinical scan. And our second pillar, which is amygdala, we created and validated our post-mortem atlas to validate our segmentation protocol, as well as we built a deep learning model using SenseEgg to enable robust segmentation on high-res ex vivo scans. And using this model inference, we can accelerate the manual labeling, and this will expand the data set and building more robust for future in vivo translation. And actually, there is still a point here, which until now, SenseEgg did really a good job. But if we can even enforce this subfield or subnuclei topology via something called like topological loss, this can enhance anatomical accuracy. So what do I mean like by topological loss? So actually, Brian had some work before, and this work he developed a topological loss, and this topological loss relies on something called the Betti numbers, and the Betti numbers measures the number of connected components and the number of holes. So we can see here that the Betti number is 1 and 0, which shows 1 shows like there is one connected component, and 0 shows there is no hole here, and here there is a connected component and there is a hole, and here there is only hole, as well as like there is a connected component here, so 1 and 1, and here there are 2 separate connected components, so they are like 2 and 0. So actually, if we can apply this topological loss with SenseEgg, then we can enforce like the model to respect the topology of the Tate gyrus, because it's really important and it's already like can be treated as a subfield. And SenseEgg didn't show that great result compared to the Tate gyrus, as well as like we can respect the whole amygdala subnuclei topology. And of course, like as always, a problem of the unit that it can introduce some segmentation holes or like segmentation discontinuity, and this of course can eliminate the segmentation holes. And our pillar 2 here, to apply the deep learning, as I said before, to new X and in vivo datasets using inference to rapidly expand the combined dataset by accelerating the manual labeling. And those are my references. And I would like to acknowledge my supervisor, my advisors, and all lab members. And thank you all. And please let me know if you have any questions.